actually talks about what some of the some of the areas in which we actually really need to, where translational research can help prevent and minimise some of the errors and mistakes that frequently occur in hospitals, reduce poor quality healthcare, reduce waste that we see in hospitals and healthcare in general, speak to variations in policy and practice. And I think some of the work that Robin Ward and the Cancer Institute have done in terms of developing EviQ, which is the evidence-based website for cancer, has really had a huge impact on the way oncologists and oncology nurses manage the care for people actually having active cancer treatment. We actually see over-enthusiastic adoption of interventions of very low value, and Lena before spoke to the importance of having a university that has a health economics unit in it, because it's one thing to make a discovery, but at the end of the day, if that discovery is not cost effective, then it's not going to be taken up into practice. But I think one of the most major things, and in my area, I would actually say, is the failure to get new evidence into practice and to get it in there in a timely way. So we started, or Lena's presentation started by talking about that translational research was really about building the gap. So I guess, just in terms of setting the scenes, what we know is one of the most critical issues in pending improvements in public health today is the enormous gap between what can optimise health and healthcare and what actually gets used and implemented in everyday practice. Yet I'm sure when you all go into when you seek out healthcare, you would expect that you would get the best that was on offer. And you would expect that it would be based on evidence. And we would, that's what we're all aspiring to do. So in many respects, I think this probably sort of crude slide really perhaps describes what, in a nutshell, probably what translational research is really trying to do. And it's actually trying to bridge the valleys of death between research and outcomes. So we actually see we've got two really quite, two steep rises associated with the basic biomedical research, but we've got this very deep valley before we can actually get that information out into clinical science and knowledge. And then once we actually amass that clinical science and knowledge, there's another huge valley before we actually can get it into clinical practice and influence health decision making. So this is an alternative model, and as I said, there's lots of different models around translational research. I'm just going to walk you through this model, and I think there's a couple of interesting things about this model, and I think it's probably applicable to all of the translational research models. I think if we look at the diagram, what we actually see is that we've got patient-orientated, we've got basic research, we've got patient-orientated research, and then we've got population-based research. What you will notice is basic research and population research kind of, in this model, sit outside of the circle, because for this team, they say that basic research and population-based research is translational, but neither type of research is by definition translational. So by itself, it's not necessarily translational. But in contrast, patient-orientation research, which fundamentally addresses issues that have the potential to translate to clinical practice and thereafter affect health, is considered to be what they consider to be translational. So what we actually have is bidirectional arrows, which are really about the way in which researchers and the knowledge interact and clinicians interact, so that we're generating new knowledge and hypotheses are generated at each step. And that the research is a continuous cycle, and that's really represented by the outside circle. So that there's this very dynamic interplay. And I guess this really comes back to the point Lena made about the importance of you getting out of the lab and really thinking about how your research is going to be applicable either at a population-based level or actually for the end users, which are the patients. So in this model, when they talk about translational research at T1, it's traditional, bench to bedside, that it's research that expedites the movement between basic research and patient-orientated research, and it leads to new or improved scientific understanding or standards of care. And all of you would be familiar with the model in terms of the phases, that it's really about taking those scientific discoveries discoveries from the lab, from the bench to the bedside. And I think we heard earlier, that that's Professor Ian Fraser in terms of his work around HPV. And I think that's a really great example of research that if you think about it, that's gone actually from identifying that there was a problem, but actually doing animal studies, phase 1 studies, phase 2 studies, which we would consider the T1. But now what we actually see is that this is actually being implemented at a population level, but also too that we've actually seen the approval process in Australia change based on the information we're getting. So we actually now have a product that is now being registered for use with young teenage boys, when originally it was just registered for women, young girls. So, and then we come on to translational research is T2. So this is really the research, and this is referring back to the model of Rubio that facilitates the movement between patient-orientated research and population-based research. And this is research that you're really wanting to generate better patient outcomes. And this is where we actually start, it's really about the implementation of best practice and improved health statuses in communities. And we see lots of great examples of that around clinical epidemiology, health services outcome research, and this has come from a Canadian model where they talk about the importance of actually involving the community or the stakeholders in this type of research, and in terms of making sure that we were able to get the key stakeholders to take up and acknowledge. And I'm trying to think, Lena used an example earlier about the biobanking was a great example where we know that it will actually make a difference, but one of the hardest things is actually getting buy-in of the stakeholders, and the stakeholders are really, in this case, would be the clinicians speaking to the patients and getting consent to make sure that we develop a really healthy biobank so people like yourself will actually have access to it, so we can actually generate new knowledge and improve care outcomes for patients with newly diagnosed with cancer and their families. And then T3, which is really starting to move into the dissemination, if you think back to that diagram before, is in this model, in Rubio's model, they actually suggest that it needs to be a promotion back into the lab and the research-based to stimulate robust scientific understanding of human health and diseases. And they talk about, this is really relevant in terms of some of the emerging disciplines such as molecular and genetic epidemiology, which some of you may be actually working into, and how biomarkers in animal models can translate into population-based screening tools. So you've already actually seen this diagram, which I think is actually a really helpful diagram in terms of, or framework or model in terms of thinking about translational research. And I guess people like myself, and in this article they talk about T2 and dividing it into T2 and T3 research is really actually the road less travelled, and that you folk perhaps down at the bench and the bedside have been really quite good in getting good products out, because there's usually often an economic imperative to get the product out of the lab out to the community. But what we now need to do is take some of that work forward on this road that is actually much less travelled. This actually is, and it's not necessarily a model, but it's from the NCI and the National Cancer Institute, and they talk about the translational continuum. And once again, we see similar elements, that we've got the basic science of discovery, which is important. Then we see early translation. They talk about many of the things that, some of them which Lena alluded to earlier when I was sitting in the importance of partnerships, the collaboration between academia, government and industry, and also to the intervention development. And this is where you will be doing, and we might actually be involved in doing phase 1 and 2 trials. And then we actually have some late translation trials where we see phase 3 trials, and they're predominantly happening in the clinical setting. And we've got all the issues that go and the challenges that go with undertaking those type of trials, not the least to mention getting clinician buy-in and making sure that we get adequate recruitment, managing governance, and usually conducting these big studies across multiple sites. But then once we've actually got that new knowledge, then there's a whole lot of work that needs to be done around dissemination, because these two components around dissemination and adoption really speak to the fact of getting research from the bookshelf to the bedside. So it's actually, we've now started to think more creatively and strategically about how do we actually get that new knowledge out into clinical practice, so that it's actually there's good uptake and that it impacts on, has a positive impact on the healthcare delivery. But also too, we need to think about the adoption. What are the drivers for the adoption of taking up this new practice? Is this your model? Is this the TCRN model?
No, I think there's something similar that Harvard has. That's a very sexy model, though. But
It is. I thought it was here. Well, you just see, you know, a Google bowel birth. But somewhere along the line, I've lost the reference. But I know I've got it somewhere. I thought it came from here, or was it earlier? Anyway, it doesn't matter. This is just another example about how you could actually conceptualise translational research. But in this model, it actually takes it to T4. So really, T0, they talk about the identification of the problem, which I think is an important component. It also, I think it's also, in these models, also always worth looking at the most important part, which is actually what's in the middle, and it's really, the goal is about human health improvements. So we've got the identification of the problem, which we haven't really heard about in previous models. If there's an assumption that that has been adequately defined and identified, then we've actually really got, similar to the other models, T1, T2 and T3. But in this one, it actually moves on to T4. And T4 is really that higher level where it's seeking to evaluate the real world health outcomes of population health practice. And I think in many respects, that might be what you, in part, may be talking about potentially. Janet. And here is an example if we apply that model in terms of thinking about translational research, and this is in relationship to breast cancer. So we see we've got we see the definitions. So this is a phase. We see the definition of each phase, and then we look at the different types of research that get undertaken at each stage, and then we actually have an example. And this whole example is actually being applied to looking at the genetic mutations associated with breast cancer. You know, so that was the identification of the problem. And then at T1, you know, the research question was, is there association between BRCA mutations and breast cancer? So what we're actually, you know, this is around the discovery of candidate health applications, phase 1 and 2 clinical trials. And then at T2, we've got what are the next question is, what is the positive predictive values of the mutation in at-risk women? And then if you think, you know, once we've developed that information, we go on to T3. And these are different teams of researchers undertaking each type of research. We then go on to the next level, which is really around looking at dissemination research and implementation once we've actually generated that evidence. And here it's actually moving on to phase 4 clinical trials. And then at the final level, the implications at T4, implications